Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about pre-implantation genetic testing. So, what we want to discuss today, the definition of pre-implantation genetic testing and types and the test procedures and the indications. Okay? Let us start with the definition. Pre-implantation genetic testing refers to various genetic assays performed on embryo before transfer to identify possible genetic disorders, and it is usually associated with IVF. Okay, I mean in vitro fertilization. Okay, this diagnostic approach used since 1990, so it is about 30 years as regard its use in assisted reproduction. Okay, so what are the types? We have BGTA, BGTM, and BGTSR. What does it mean? BGTA, pre-implantation genetic testing for aneuploidy screening. What is aneuploidy? Aneuploidy means extra or missing of one chromosomes. Ploidy means number of chromosomes. So if we have missed one chromosome or extra one chromosome, this is called aneuploidy. Okay, so if I'm searching for screening for aneuploidy, it is called pre-implantation genetic test A. In the past, it was named BGS, pre-implantation genetic screening. Okay, okay. The next one is BGTM, BGTM, pre-implantation genetic testing M, for monogenic or single gene defects. For monogenic or single gene defect, either autosomal recessive or dominant or X-linked and so on, or sex-linked. Okay, okay. And this BGTM formerly was named single gene BGD, pre-implantation genetic diagnosis. Okay, the third one is BGTSR, pre-implantation genetic testing for structural chromosome. Okay, for chromosomal structural arrangement. SR for structural rearrangements, like abnormalities in chromosomes, like translocation and so on. Okay, and this was named in the past chromosomal BGD, chromosomal pre-implantation genetic diagnosis. So the recent used names BGTA, BGTM, and BGTSR. Okay, we need to take a biopsy to do genetic study, and this biopsy will be taken from where? From the polar bodies, first and second polar bodies, from the oocyte, or from the blastomere, from the cleavage stage embryo at day 3, or from trophoectoderm, from the blastocyst. So either from oocyte, from the first and second polar body as you see in this picture, or from third day cleavage stage embryo, 1 or 2 blastomere from this one. Okay, or from the trophoectoderm, from its outer part trophoectoderm, at the blastocyst stage. Okay? Okay. Usually this is at day 5. Okay? Okay, the blastocyst, or day 6. Okay, so let us start with the biopsy from the oocyte. In the earliest stage, both the first and second polar bodies are extruded from the oocyte as it completes the meiotic division after ovulation. This is the first polar body. And the fertilization, this is the second polar body. So, the first polar body is available after ovulation or at the time of the ovulation. Okay? And after the first meiosis. And the second polar body is available after fertilization with the second meiotic division. Okay? Okay. So as you see in this picture, this is the first polar body and this is the second polar body. What if the mother was a carrier for a genetic defect? Okay? And we found the polar body is normal. This means what? This means that the genetic defect was transferred to the oocyte during meiosis. Because she is a carrier and I found the polar body is free, so the oocyte is carrying the genetic defect. Remember this point very well. Okay? Okay. So this strategy focus on maternal chromosome abnormalities. Okay? Okay. What about the biopsy at the cleavage stage embryo or day 3, as I said before? It can detect genetic abnormalities arising from either the maternal or paternal genetic material. Okay? Because we are taking the biopsy now from cleavage stage embryo, so it represents maternal or paternal genetic material. While from the oocyte, it represents only the maternal. Right? Okay. Remember this very well. So, from the polar body, it represents the maternal. From cleavage stage embryo or day 3 embryo, it represents maternal and paternal one. Okay? Okay. Cleavage stage biopsy takes place after the first few cleavage divisions when the embryo is composed of how many cells? 6 to 8 cells. These cells are called blastomeres. These cells inside, as this in this picture, is called blastomeres. So it is about 6 to 8 cells. I need only 1 or 2 cells at maximum. Okay? So aspiration of 1 blastomere or 2 from the embryo. Then do analysis of the 2 cells. And by this way, if I took 2 cells or 2 blastomere, it will improve diagnosis. But there is disadvantage if I took 2 in spite of 1 blastomere. It was found that it may affect implantation. So the pregnancy outcome is disturbed or decreased or less prognosis if I took 2 blastomere. If I took 1, it will be better. However, the analysis will be improved with 2. But if I can do it with 1, this is better as regard for better outcome, for better implantation, I mean. Okay? Remember the advantage and disadvantage of taking 1 or 2 blastomere for analysis. Okay. The third biopsy can be taken from the blastocyst. This is the third option. Is sampling the embryo at the blastocyst stage when there are about 100 cells, as in this picture. Okay? Blastocyst from 5 to 6 days after insemination. From 5 to 6 days after insemination. Okay? Okay. How many cells? I need from 3 to 10 trophoectoderm cells. And look to this picture, please. I'm not going to take from the inner cell mass. I'm taking from the trophoectoderm, from the outer part here, which will be the future placenta. Okay? I will take 3 to 10 cells of the outer layer of the blastocyst. Okay? A disadvantage is that not all embryos develop to the blastocyst phase in vitro, and when they do, there is short time before embryo transfer needs to take place. This is the disadvantage. Okay? Okay. Okay, again, for the test procedure, I'm going to take the biopsy from the polar bodies, either the first polar body extruded from the mature oocyte with the first meiotic division at the time of ovulation, or from the second polar body with the second meiotic division at or after fertilization. And this picture show you the polar bodies, the first and second polar body. Okay, this is the second biopsy from the cleavage stage embryo, usually at day 3, and this is the blastomere, and as I said, 1 or 2 blastomere will be aspirated and analyzed. Okay, and I said implantation has a problem if I took 2 blastomere, but implantation is better, will be better if I took only 1 blastomere. But the analysis is better as a result of the test of pre-implantation genetic testing is better if, of course, if I took 2 blastomeres. Okay, this is the third one with the trophoectoderm. This is the trophoectoderm cells from the outer side of the blastocyst. I'm not going to take from the inner cell mass. I'm taking from the outer surface of the blastocyst. This is called trophoectoderm sample. The benefit of trophoectoderm sample is avoiding biopsying the inner cell mass that gives rise to the fetus. However, in case of mosaicism, it may not represent the constitution of fetal tissue. There is also the possibility of false positive results. Okay, what is the next step? It was in the past using the FISH, F-I-S-H, which is fluorescence in situ hybridization analysis, that utilized selected chromosomes. Okay? But most evidence with this method didn't show improvement in IVF outcomes. So using of fluorescence in situ hybridization analysis, which utilized selected chromosomes, was found not to improve the IVF outcome. But what is used now is better. Which one? Now, pre-implantation genetic testing A is routinely performed on 24 chromosomes, not on selected chromosomes as in the previous FISH. So now the test is performed on 24 chromosomes, initially with array CGH, And now, with the use of more advanced technology, such as next generation sequencing, this is the updated one, next generation sequencing. Okay, so array CGH, then the most updated is the use of next generation sequencing, and we are performing the test on 24 chromosomes, not only on selected chromosomes as in the previous fluorescence in situ hybridization analysis. Okay, with 24 chromosome analysis, evidence for BGTA is more mixed, and few randomized controlled trials comparing elective single embryo transfer of euploid embryo determined by preimplantation genetic testing A versus morphology grade based selection of embryos found no inferior or improved pregnancy rate amongst the BGTA group. I mean, with the use of analysis for 24 chromosome, okay, and use of single embryo transfer, okay, when we discussed some studies, we found that if we choose the embryo according to the morphology grade or BGTA test, more or less they are equal. I cannot say there is one better, okay? But retrospective data analysis 2011-2012 from National ART database found a possible increase in likelihood of live birth in women aged more than 37 who utilized BGTA, okay, who utilized preimplantation genetic testing for aneuploid. Okay, what about the opinion of American Society for Reproductive Medicine? It doesn't recommend for or against the universal use of preimplantation genetic testing for aneuploid. However, it does acknowledge the potential benefits, particularly in elective single embryo transfer candidates and the resultant decrease in multi-gestation pregnancy. I mean, they said if we did this test for aneuploidy, the preimplantation genetic testing, and if we after doing this we transfer only single embryo after doing this test, okay, we are avoiding the multiple gestation, and all of us know the complication of multiple gestation. Okay, so collectively we can say the indication for preimplantation genetic testing is classically used for selection against aneuploidies and the genetic disorder, whatever it is, X-linked or not, autosomal recessive or dominant. It can be used in more ethically controversial avenues such as in sex selection. Those who needs boy or girl can use this for sex selection, but this is ethically not approved by many obstetricians, and I am one of them. I refuse to do sex selection just for the family to have a boy or girl and not for the medical reason. So this a matter of controversy ethically all over the world. Okay, and some obstetricians refuse to do that, and I'm one of them. Okay, Individuals in specific communities, such as dwarf and the deaf community, have been reported to request selection for dwarfism or genetic deafness. That's all in this lecture. Thank you. Please remember my 4 books published on Amazon: Textbook of Obstetrics, Textbook of Gynecology, Contraception Handbook, and the Multiple Choice Question Book. You can find here the my site on Amazon as a user, and you can find this book, and you can have a sample of the book to read. Thank you.